Okay, so I'm going to talk about multinational data collection. Data collection is itself not an inherently very interesting topic, so I'm going to try not to talk for too long, and I'm going to try not to be boring, but you can be the judge of whether I've actually achieved either of those two aims. We all ultimately want the same thing, and that's good outcomes for patients. And I'm going to talk about different approaches to how this can be achieved between different centres. So in the UK, you've probably all heard about controversies regarding heart surgery in infants, and that's been an ongoing problem. And so if you have enough data, you can produce plots like this, which show individual centres and whether, given the number of patients that they're seeing and the number of deaths that occur when they focused on mortality, then are they in an alert area or an alarm area? Okay, and so this data collection was compulsory. Then actually what happens is when you take away the dots and you make those into individual hospital abbreviations, then it creates an instant tension between different hospitals, between hospitals and patient families, and potentially between hospitals and patient organisations, which in the case of congenital heart surgery was stirred up by the UK press. And so Graham's already spoken a little bit about the GIRFT report, so getting it right first time. And there's a poster outside, which I hope you've seen and Graham's also referred to. I won't talk about it in detail, but essentially there was a deep dive to 22 specialist trusts and 67 non-specialist trusts into paediatric general surgery. And so essentially the bottom line is they wanted surgical expertise to be concentrated in the right place for the right patients. And so essentially this is a top-down approach. So in other words, some kind of regulatory framework to say which hospital should these patients receive their treatment in. But actually that may focus on one or two key outcomes. Mortality, thankfully rare in esophageal atresia, but other things like esophageal strictures or anastomotic leaks, etc., are also important aspects that one could focus on if you wanted to take this top-down approach. But actually, as you all know, there's lots of different steps undertaken in the care pathway of esophageal atresia patients in these centres. And even in the good centres, is every step of the process undertaken optimally? There's all sorts of different things that could be optimised. Complications happen even in the best centres, so how can we improve outcomes in all centres and for all types of esophageal atresia? So, for instance, what's the optimal treatment for long gap esophageal atresia? Delayed primary anastomosis, FOCA, gastric transposition, jejunal transposition, colonic transposition, all looking into our crystal balls and into the future for a tissue-engineered esophagus. And I'm sorry, Natalie, but I couldn't resist transposing you onto Professor Trelawney looking into the crystal ball here. And so a few years ago, then the British Association of Paediatric Surgeons set up this system called BAPS-CAS. And what they did was used a methodology where for 1 year, they looked at all the babies born with esophageal atresia and looked at lots of different aspects of their care. So in this year, then 151 infants were admitted to 28 paediatric surgical units. And here on the different esophageal atresia types, I've put down the numbers of each type that were included. And so obviously type C OA TOF was pretty well represented, with rarity of the other types. But that leaves us with a problem if we then want to start looking at optimal care for long gap esophageal atresia. It's difficult to reach conclusions where you've got 15 patients in 28 different units. In other words, about half a patient per unit per year. So you either need more centres or a longer time period, or both. Obviously, a longer time period, you're then looking at potentially what differences occur during that time period in different procedures. So, for instance, minimally invasive techniques, different ways of dealing with strictures, and so on. And so that's really kind of a top-down approach. But the other approach is a bottom-up approach. And the bottom-up approach here was spearheaded actually by Eaton and by TOFS, this was before Ernica, I think, Graham, right? Yep, it was. Yeah. And so this was a patient-led international study of long-term outcomes of esophageal atresia. And I'm just showing you an example from the data that was obtained from this survey. But then from the bottom-up approach, we also took the approach, well, we need to start somewhere. So Graham's already mentioned these consensus statements. This is a consensus statement for long gap esophageal atresia. And you can see here that that Graham, Anka, and Joanne from Eaton and the various Eaton constituent associations were very heavily involved in this. And so we had a fairly intensive consensus meeting over 2 days and voted on 97, discussed and then voted on 97 different items. We had controversy over 19 items, and that's only the ones that we actually got to a vote on. There were some aspects, specifically for long gap atresia, where we didn't even think we could put a question to a vote. So, but it's a start. So obviously, so this has been criticised by paediatric surgeons. They're saying basically, who are these experts that come up with these guidelines or this consensus statements? But the other approach that we can take is what I'm going to talk about and what the title of the talk is, which is an international collaborative data collection, and that's called a registry. So what we want to do is collect detailed data on different stages of the patient pathway in lots of centres. And so this is the bottom-up approach that relies on honesty and goodwill of all the participating centres. Because what we have to remember here again is what I said at the beginning, because actually we all want the same thing. We all want the best outcomes. So clinicians, surgeons, doctors, nurses, everyone, parents, patients, patient organisations, we all actually want the same thing. And so provided it can be done in a non-confrontational way, collecting multi-centre, multinational data does not have to be a fight against my centre, your centre. And so, for example, here, if you did this congenital heart surgery graph in a non-confrontational way, so the blue centre can see its own position on the graph, and can see the red dots, but doesn't know which ones the other centres are, then the blue centre might think, okay, well, I'm near the alert area here. Maybe there's something I need to fix, or maybe it's something I need to look into. And there might be a reason why they're there that's completely unconnected with patient care, or there might be something in the patient pathway that can be changed. So what is the EPSA-Ernica registry? So currently the EPSA-Ernica registry is registering the following conditions. So esophageal atresia, CDH, omphalocele gastroschisis, and Hirschsprung's disease, and we're developing more to fit into this registry. And it's a pretty wide data collection. So these are the centres that are currently contributing to the data collection, and more are on the way. And so patients are registered into the clinical audit, and this enables comparisons of processes and outcomes between hospitals. We can identify areas of best practice or with room for improvement, and that can advance the quality of care. So this is just an example of the interface by which people put in data. And so it's quite complicated in how it's done, but effectively what we have is a very, very, very highly secure, very robust database that it goes into, that is actually based in the Netherlands, but is used by the Dutch Health Service for clinical auditing, and it's NHS grade security of data. And so you, as I say, you include the data, but then actually what you can then get is the type of graph I was showing you earlier on. So you see these kind of funnel plots, which are made live, so you can see today, how am I doing compared to the other centres? You don't know what the other centres are, but you can see how you're doing. And you can look at particular complications. So these are just mocked up examples. I can't show you the live data, but for instance, you could look at stricture rate, you could look at anastomotic leakage or whatever. And so this is called a Codman dashboard. The name Codman is after in the early part of the 20th century, there was an American called Codman who basically invented the audit process, and that's why it's called a Codman dashboard. But importantly, we need to collect the right data. So Rebecca earlier on gave a talk about a core outcome set. We developed what we call a core indicator set as a parallel process. So we used the same literature review to start with, and went through a three-round process to define what the best indicators were. Now, indicators are slightly different from outcomes. So indicators can also include things like processes. So did you do an ultrasound of the kidneys, for instance, which might not be an important outcome, but it's an important indicator of how patients are seen. And so these data are confidential, so I can't share the slides with you, unfortunately. But this is kind of what we have every year is an Ernica feedback meeting where we choose a condition that we feedback live data to all the centres that are participating in the registry. This year it was esophageal atresia, so we were able to focus on anastomotic leakage for our feedback session. So this is the total number of patients that are registered. This is specifically the esophageal atresia patients, and you can see we're starting to get good numbers across all these centres. And then, so just as an example, this is reported anastomotic leakage in long gap patients. There's 38 so far in the database. But we can look at factors associated from all the other data we're collecting with anastomotic leakage. And hopefully, if we will be able to start to tease out what factors might be more associated with anastomotic leakage. So here you see just an example breaking down between long gap patients that had a delayed primary anastomosis, that had a traction, so the Fokker procedure, or an esophageal replacement procedure. And also you can do benchmarking and look for leak rates above average and leak rates below average. But what will that enable us to do? So I said earlier on that we'd produce this consensus statement, but hopefully what we do is we, in 2026, which is projected because these consensus statements have a lifetime over which you're supposed to revise them, hopefully we can, when we come to revise the consensus statement, we've got all this data that we can apply to those 97 questions and 19 especially controversial items that we tried to vote on, and also maybe some of the items we weren't able to vote on in the first time round, to try to improve the consensus statement. And that's how we think we can hopefully improve quality of care.
I will have retired by then. So.
Well, I was going to keep the names on, and then I thought, oh, well, actually looking at the list, I'm not sure who's, yeah. So it all looks quite easy, but in fact, it's quite difficult, and it's very difficult from a bureaucratic perspective. So it requires hospital legal teams, discussions, adaptations that are necessary, adaptation of the agreements and signature. There's variability in terms of GDPR interpretation. So although GDPR is supposed to be the same all across Europe, the way different hospitals, different countries, and even different hospitals in the same country interpret GDPR is quite different. Consent is also an interesting aspect. It's an audit, so from some perspectives, one doesn't need consent to include those data in an audit, but in some territories that plays out differently. Brexit made that even more complicated for those of us in the UK. But there is hope, and there's also a vision for the future, and which is that hospitals are really good at collecting lots and lots of data. And now we already have electronic patient records in most centres. So there is a vision where we can actually transfer data, either directly, expensive and technically quite challenging to do that securely, or indirectly into the registry. Of course, that is a dream, but it does involve even more bureaucracy, even more GDPR, and unfortunately, the currency of your choice. But I hope that I've at least illustrated why multinational data collection might be useful, and might be useful specifically in OA TOF. And I'd like to thank all the people that have been involved in here. Graham, Eaton, TOFS, Ernica, which has been led by Renee, who we hope was going to be here, and Nadine, who is the PhD student in Rotterdam, who's been really involved in revising the esophageal atresia data set for the registry. I think I'll finish there.